You can go in a few seconds. Okay, proceed.
Hi everybody, I'm Tahrir Rasool. I'm presenting with Kerry Calway. We're presenting about appraising new evidence. So we could not do a presentation on appraising evidence without giving an overview of the steps needed in practicing evidence-based medicine. So you'll see on the screen that we have a cycle, and this cycle is repeated with each new dilemma or question, but the patient is always in the center. So although the presentation is focusing on step 4, which is appraising the evidence, we still need to give a background on step 3, which is acquiring evidence using reputable sources, because there is no use in appraising poor or unreliable sources of information. So in research, there's a hierarchy of evidence based on study design type. So if you look at the pyramid in the corner, as you move up the pyramid, the available literature on it decreases, but the relevancy and quality of this literature increases. So at the top, you have your meta-analysis and your systematic reviews and your randomized control trials. So your systematic reviews and meta-analysis are considered to be the highest quality evidence on a research topic because their study design reduces bias and produces more reliable findings. A systematic review refers to the entire process of selecting, evaluating, and synthesizing all available evidence on a specific topic. And meta-analysis refers to this statistical approach to pooling the data derived from all the randomized control trials, including the systematic review. So it's also important to look at where we look for evidence. So we can look at the pre-appraised sources, such as UpToDate or the Cochrane Library, or we can look at raw randomized control trials, such as PubMed or Google Scholar, and we can also make use of our clinical guidelines. We're also going to look at the grades of evidence, which I'll discuss in the next slide. And it's also important to know how to look for information, so using your mesh terms or your Boolean operators. So with regards to grades of evidence, the grading approach is using guidelines or in some resources such as UpToDate. It classifies the recommendation of evidence as either being strong, which is grade 1, or weak, which is grade 2, and further takes into consideration the benefits, the risks, the cost, and degree of confidence. It's further graded according to the quality of the evidence as either being grade A, B, or C, which is high, moderate, or low. So on this slide, you can see there's a table. I won't go through the entire thing, but if you look at the first one, it's 1A, which that recommendation says it's a strong recommendation with a high quality of evidence. The benefits outweigh the risk and the burden, and the quality of evidence shows that the evidence is consistent, a randomized control trial is used, and any further research done will most probably not change the confidence of the benefits and the risks. If you look at the bottom, you'll see 2C, which is basically the opposite of 1A. It's where you have weak recommendations with low quality of evidence. The risks versus the benefits, there's uncertainty in the estimated benefits, risks, and burdens, and the quality of evidence are majorly flawed, and therefore the effect of the study is questionable. So in step 4, where what we will discuss is appraising the evidence. It's important to also just define what appraising the evidence is. And it's a systematically examining research to assess its reliability, value, and relevance in order to direct clinical decision-making. So the 3 main questions you want to ask is the study internally valid? Meaning, are there any bias or confounding? Then what are the results? So how precise is this effect? And the third question is, what is the external validity? Meaning, how will this help my patient? So there are very important concepts that need to be understood before you can appraise evidence. So if you talk about validity, we get internal and external validity. Internal validity is the capacity of the study to yield the truth about the study population. So meaning, have the authors measured what they said they are measuring? So an example of this is the effect of clopidogrel use on clinical outcome after acute MI. The study needs to define what is classified as an MI. Otherwise, anyone with an acute chest pain could be included in the study. Thus, researchers must make sure all participants truly have an MI to be included. If more of these fake MI patients were allocated to receive clopidogrel, outcomes may appear falsely significant compared to if only true MIs were included. Internal validity also depends on the absence of bias and confounding and how the study measured the variables. Then to move on to external validity, it's the ability to make generalizations to the broader study population. External validity is a judgment and not a statistical exercise. By including a wider variety of participants in a study, it increases external validity or generalizability, but decreases internal validity, since confounders and bias may occur more. Hence, there's a trade-off between internal and external validity. So if you look back at the MI example, we can ask what ages of patients were included. Were patients with other comorbidities like diabetes included? And can the conclusions drawn from the study be applied to patients who may not have qualified to be included in the study? So essentially, we're asking, how does this affect the patients that we see? So we also have to look at precision. Precision in a study is the degree of similarity of results if the measurements are repeated on the same group or same individual multiple times. So if you have to measure again, you should get very similar results. But precision is based on or dependent on sample size. A larger sample size will give you a better representation of what is happening in your study population, and therefore your confidence intervals will be narrower and your association is more reliable. The second one is reliability of measurements. So variability can come from the instruments you use, but also the participants themselves and the environment in which the study is taking place. So study results may be precise, but invalid. So a study shows narrow confidence intervals or low p-values, but bias or confounding are present. There's also results of a small study may be valid, but not precise. So the aim is obviously to get both good precision and good internal validity, which is the third circle you'll see on the slide.
Okay, so now we're going to go to the actual steps of assessing internal validity. So to appraise bias in an article, we need to look at how the study was conducted. So we need to look specifically at the methods section. So bias is defined as any trend in the collection, analysis, interpretation, publication, or review of data that can lead to conclusions that are systematically different from the truth. There are two main categories of bias. These are selection bias, so how participants are selected or volunteer from the source population, and then information bias, which are systemic inaccuracies in measurement, recording, management, and analysis of data. So here are examples of different types of selection bias. And this table explains that what each type is, and it gives you an example. So I'm just going to focus on a few. So if we look at volunteer or non-response bias, they're quite similar in that it assumes those who volunteer or those that don't respond may share different baseline characteristics compared to other participants. So for instance, if we use an example of asking healthcare professionals to volunteer to answer a questionnaire about antibiotics correctly, those who volunteer may be different from the base population in that they may have a special interest in infectious diseases. And thus know more than the average general population of doctors that we are including in the study. And then in the same respect, those healthcare professionals who choose not to respond to the questionnaire may feel inadequate in their knowledge or experience on the matter. And so they share that characteristic. Another type of selection bias is the healthy worker effect, which occurs because healthy individuals are allocated to work with higher exposures as opposed to workers who get sick due to their work exposure and are moved out. So this reduces the association between an exposure and a health outcome. So an example would be if we looked at pulmonary TB in mine workers. So miners who develop TB disease are moved out from underground work to above ground or even retrenched or given long sick leave, thereby reducing their exposure to the overcrowded work environment and their peers who may have TB. So if we then take the sample from those miners who are only working in the mine, that we will be left with only those workers who have less risk of developing active TB disease. Okay, and then another very important one is loss to follow-up. So this is important because participants may drop out due to a risk factor or disease severity, or because of the intervention itself. So it's important to note that if a study has a loss to follow-up of more than 20%, you should be concerned about bias. An example here is if smokers are more likely to leave the study if they develop lung cancer or COPD in a prospective study. Okay, so how can studies limit their selection bias? So once you've assessed that a study is at risk of selection bias, you need to check to see if the researchers have tried to counteract this in their methodology. So researchers could use blinding of participants, researchers, or statisticians. So that would be single, double, and triple blinding, respectively. Or they could use a recruitment strategy. So an example would be if you're looking at patients who met the inclusion and exclusion criteria of the study, you would sample every third person in the clinic, for example. The studies can use a randomization strategy. So this is where researchers do not choose who goes into each group, either the treatment group or the placebo group, but rather that some random process allocates people. And then it's important to then also compare the demographics of those who were lost to follow-up or those who left the study or didn't respond, and compare the demographics of those who remained to see if there was any actual difference that we could detect. Then another important concept is this intention to treat analysis. So in randomized controlled trials, researchers may want to exclude non-conforming participants to ensure that comparisons are made only between those who strictly adhered to the planned treatment, so that the true effect of one intervention over the other can be assessed. So if you had to do that, that would be classified as per protocol analysis. However, if you analyze data like this, it creates multiple problems. So firstly, it violates the principle of randomization because some participants who were in the study group may have dropped out more from the treatment group as compared to the control group. The non-compliance may be related to a particular intervention or disease severity. It may lead to significant reduction in your sample size and hence your study power. Exclusions of participants can introduce bias because the researchers may choose to exclude participants who are not doing well in their study. And then the proportion of responders among those who completed the treatment actually creates an exaggerated estimate of the treatment effect because this doesn't really accurately reflect the beneficial way of what we would expect the treatment to have in a clinical practice. So we don't expect all our patients on a certain treatment to be 100% compliant, and thus doing per protocol analysis will overestimate your effect that you expect to get. So to avoid these pitfalls, studies need to use the intention to treat analysis, which is where you analyze all randomized patients in the groups that they were originally randomly assigned to, regardless of the treatment they actually received or their withdrawal or deviation from the protocol. So in a randomized control trial, you need to see and check that analysis was done in the intention to treat analysis. So often, if this intention to treat analysis doesn't yield significant results, the authors may also calculate the per protocol analysis, which does show significance, because journals don't want to publish things that don't show significant results. Okay, next we got information bias. So you get different information bias depending on the source of your information. So you could get subject variation, observer variation, and then instrument variation. So I'm just going to go through a few of these. So recall bias is especially important in case control studies because cases may more closely scrutinize their past history, looking for ways to explain their illness. So here the example is if we asked mothers who had children with congenital abnormalities if they were previously exposed to pesticides, those mothers who had babies with the abnormalities may think harder about any sort of exposure they may have potentially had. Then the Hawthorne effect is described when study participants change their behavior because they know they are being monitored or enrolled in a trial. So for instance, those enrolled in a weight loss study assessing a change in diet may exercise more while being enrolled in a study because they know they're being weighed every month or every week. So to balance this effect, it's important to have control groups who have the same level of interaction with the research staff and measurements so that you can cancel out the Hawthorne effect. And then in terms of the tools and equipment that the study uses, we need to ensure that these are standardized, valid, and calibrated. So I want to make just a point of this in that this is very important for questionnaires. So a lot of people, if you want to specialize and you're doing your MMed, many people choose to do questionnaires. The problem is that people don't understand that their questionnaires first need to be validated in a pilot sample to make sure that you are measuring what you actually think you are measuring. So for instance, here, if you were doing a questionnaire about healthcare professionals' knowledge of antimicrobials, but you use medication that are not typically in use for that sector, it might be giving you a false measurement of not what you actually want to be measuring. So that's just an important criteria. Okay, so how do you need to then assess that a study has attempted to limit the information bias? So again, blinding is important. Also, in terms of case control studies, researchers need to have had an independent ascertainment of exposure and case status. So researchers need to separate their participants and decide whether or not they have been exposed or not exposed to whatever variable you're looking at, and then independently, so a different researcher decide whether or not the participant has the diagnosis or not. Obviously, then ensure that all your tools are standardized, validated, and calibrated, and like I said, putting through your tests through piloting. Okay, another important concept in understanding internal validity is confounding. So this is defined as the distortion of an apparent association between an exposure and an outcome by a third variable, which is associated with both the cause and effect. So a confounder must have the three requirements in order for it to actually be a confounder. So firstly, it must be associated with a dependent variable. So in other words, it must be unequally distributed between the exposure groups and non-exposure groups. It must be an independent risk factor for the disease, and it mustn't be an intermediate factor in the causal pathway. So confounding variables result in over or underestimating the impact of your independent variable on your dependent variable. So an example is if we look at the effect of dust exposure on the development of COPD, a confounding variable here would be smoking. So if we look at the requirements for a confounder, so number one, smoking is associated with the exposure in that more or less people who smoke may have been among those who were exposed to dust as opposed to those who were not exposed. So it was not equally distributed between the exposure and non-exposed groups. Then smoking, we know, is an independent risk factor for COPD, even in patients who are not exposed to dust. And then we know that the presence of smoking doesn't promote dust exposure as part of a causal pathway. So smoking as the confounder, therefore, meets all of these three criteria. And then we can say that it is a confounding variable. So how do studies limit confounding variables? So they can do so at different design stages of their studies. So at the design stage, we can restrict patients. So in the dust exposure example, we could exclude all smokers, and thus we know this would not be included and contributing to the effect we are seeing. Another way is that we can match cases and control. So you select a comparison group that matches with the treatment group. So each member should have a counterpart in the treatment group with the same value of potential confounders. So for instance, you match male 45-year-old smokers in both dust exposed and non-dust exposed group. The problem is with this is actually finding matches. Then at the design phase, you can use randomization. So with a sufficiently large sample size, all potential confounding variables should even out and have the same average value between your different groups. At the analysis phase, you can control for confounding with statistics. So with stratification, you look at the effects of the independent variable and the dependent variable according to different confounder groups. So you basically, so in our example, we would say, what is the effect of dust exposure on the development of COPD in smokers? And then compare that to the development of COPD in dust exposed versus non-dust exposed people who don't smoke. And then another way that you can account for it is to do a multivariate analysis. So often you'll see in studies, they say the raw or the adjusted relative risk, or the raw and adjusted odds ratio. So that's taking into account before and after statistical analysis with the confounder, which means that the association between the exposure and the disease will differ once we've taken into account the confounder. Okay, so that was all the hard stats part. Actually, that was a lie. Let's, next, second step is then evaluating how to actually evaluate the results of your study. So the different types of statistical tools used in research will be dependent on the study design. So here, if we look at our randomized control trials, the therapeutic or interventional trials, most likely you're going to be using experimental event rates, so that's EER, and then control event rates, and then relative risk, which are RR, and then number needed to treat. So this is really important, number needed to treat, because most studies don't actually calculate this, usually because it's it shows that the study is not great, like in terms of the results. So you will have to actually calculate that yourself. So I've included the calculation here in the top. So number needed to treat is equal to 1 divided by the control event rate minus the experimental event rate. So if we were looking at the COPD example, we would say 1 divided by the rate at which the non-dust exposed group had COPD minus the rate of COPD in the dust exposed group, and then basically work out the number needed to treat. And so here, that gives you a sort of value in terms of the therapy, in how many people you need to give the intervention to in order to save one person from having the outcome or having the disease. So how many, if we're looking at clopidogrel use, like how many patients do we need to give clopidogrel to in order to prevent one person from developing cardiovascular disease? Okay, so that's therapeutic studies. Then we can look at diagnostic studies, which use sensitivity, specificity, positive predictive value, negative predictive value, and likelihood ratios. Prognostic factor studies use hazard ratios and survival curves, which are also known as Kaplan-Meier curves. And then systematic reviews use heterogeneity, which is represented by I2, and then forest plots. So I've just included a random forest plot here that I got off the internet to just remind you what forest plots look like. And so here you can see that each study included in the meta-analysis is on each line, with the point estimate represented by the block. The size of the dark block represents the study size. And so therefore you can see the one nearest the bottom has the largest block, which means it had the largest sample size relative to the rest of the studies. And then the bar going across represents the confidence intervals. You can easily see here that the diamond shape then represents the combination of all these together. So you can sort of just do an eyeball of this forest plot and see that there is a definite effect when we pull all of these results together. Okay, so we have all of these statistical measures. How do we understand it? And how do we know whether or not they're significant or not? So that's when it comes to p-values and statistical significance. So statistical significance is defined as the measure of probability that the results were due to chance rather than to the real effect of the treatment or intervention. So the p-value ranges from 0 to 1. The smaller the p-value, the stronger the evidence that you reject the null hypothesis. So an example of a null hypothesis is that you are assuming that the two interventions you are comparing are equal. So if your p-value is less than 0.05, which is statistically significant, it means that we have strong evidence against the null hypothesis. And so we can say we reject it. So we reject that the two interventions are equal. And this means that—
Will you wrap up in the next 3 minutes?
Okay. So this means that there is less than 5% probability that the results that we're seeing are due to chance alone. If we have a higher than 0.05% probability, this indicates strong evidence for the null hypothesis, and thus we fail to reject the null hypothesis. Note, we never say that we accept the null hypothesis. We just say that we fail to reject it. Okay, confidence intervals. So we use 95% confidence intervals because we use the 5% p-values. So this gives us 2.5% on either side of the confidence interval. And basically, confidence interval means that if you repeated the study multiple times, we expect that 95% of these confidence intervals will contain the true population mean. So the wider this interval is, the less sure you can be of what the actual true value is. So an example here is if we said the systolic blood pressure was 120 plus minus 19, so basically it ranges from 101 to 139, as opposed to a confidence interval to 112 to 131. We are more sure of what the true population mean is between here than this larger range. So when you have a confidence intervals where you're comparing the difference between two groups, the null value is 0. So if you're comparing the difference between blood pressures, between cases and controls, if your confidence interval includes the value of 0, it means it's non-significant. As opposed to when you compare a ratio between groups, if the confidence interval includes the value of 1, then it's non-significant. So for instance, if you're looking at a proportion of patients who died versus treatment and control, the proportion there, if it is equal to 1, means that the two groups were the same. Okay, so p-values and confidence intervals are all affected by the effect size, so meaning the difference between the two groups that you wanted to detect, the sample size, and then the spread of data. Then it's important to consider clinical significance. So this refers to, will the study actually make a difference in my clinical practice? So do results of the trial make an impact to existing treatments? Will they make a difference in the lives of those getting the treatment and how it's implemented? Okay, so then external validity, I'm almost done. So basically this is asking, does this study apply to my patient? So if we look at the study, we need to look at, were the study participants similar to my patient? So I've said here, look at table 1. So usually table 1 in a randomized controlled trial describes the demographics of the patients who were enrolled in the trial. And you can then see if your patient actually fits into these demographics. Were all of the outcomes considered? Were the confounders considered? Were there side effects and adverse events that were reported or not reported? Were outcomes directly measured, or were they using surrogate endpoints? And was the follow-up sufficiently long enough? So if we're looking at the effect of medications on preventing disease, if they only followed up patient for 1 year, was that really long enough? Should it have been 5 years, 10 years, or longer? And then if we're looking at diagnostic studies, will these test results and its interpretation be satisfactory in my clinical setting? So this a diagnostic test very much depends on the prevalence of the disease in the population. So if your study comes from a population that has similar prevalence of disease, we can say yes. And then the main one as well is, are the benefits worth the potential harms and cost? So here, that's where you are looking at your number needed to treat, which is why you need to calculate it, versus the cost and the side effects of the treatment. And then step 5 of our circle is to then apply this to our patient. So once we've gone through the appraisal and we decide, okay, this is relevant to our patient, it will make a difference to our patient, you then still need to actually discuss it with your patient and include them in the decision-making process. Help them understand the pros and cons, understand their concerns and what's important to them. And that's it.
Thank you very much. Well done. Nice. Thank you, Kerry. I think that if any of you are doing I think Kerry raises important issue, which is important for you in this forum, is what difference does it make to my patients? And I think that clinical significance is an important one to keep in mind. When you're looking at the sort of an assessment of evidence, from a practical practice point of view, and this applies to every one of you, not only those who are doing an MEd, the key thing is that when you are looking at, when you look for evidence, when you look to say, what should I do under particular circumstance, look for information with the search word including systematic review. So when you're looking, try to include that in your search terms and find systematic reviews. You may also look for meta-analyses, and that may help you. They tend to be higher on evidence. When you're looking generally to explore guidance in your practice, guidelines are important. But when you look at guidelines, don't just accept guidelines. Look at the detail in terms of the references and see how well backed are those guidelines by meta-analysis, systematic reviews. Now, systematic or reviews are generally, meta-analyses are made up of a particular type of evidence, which is very quantitative and is randomized controlled trials. It's what Kerry went through. And if you want to look at how do you assess that in future, if you got this information, it's useful. But there's a guideline called the PRISMA guideline, the consult guideline, that is very useful. And you can use that when you're sitting with a paper and trying to make an assessment, is this randomized controlled trial or good value or not? But like there's the consult guideline, there are a number of other guidelines. So if you're looking at a case control, which is actually a retrospective study, you have different sets of guidelines. For meta-analysis, different sets of guidelines. You've also got guidelines for qualitative type of research. So that is also evidence. So don't underestimate qualitative type evidence. So look around and understand this terrain of how do you make a judgment call about evidence. You're going to get all sorts of things coming your way, and you must not just take expert opinion. You must go look and search for yourself. And this is the way in which you can go about it in your practice. So I hope that's been useful. Thank you very much, Kerry and team. I'm sure that people appreciate it. It'll certainly carry weight when you do any research. But in your average study, I think you need to also be able to judge the validity of any study that you come across. So hopefully this has been helpful. Thank you very much, Kerry and team. Any questions? Any comments? I see no hands up.